This is the Hype Squad with Charli McConnell, a podcast where women can be full of themselves and brag about what they're good at. Each week, we're going to bring you conversations covering topics like motherhood, life, relationships, business, and everything in between, because anything is possible with your very own Hype Squad. What's up, ladies? Welcome back to the Hype Squad. I'm Charli McConnell, your host, and today we have Dr. Emily Allen McInnis. She is an OBGYN who's passionate about women's health and small town roots. She studied at Auburn, earned her medical degree in South Carolina, and trained in Mississippi, but she made history back home in Sylacauga as the first female OBGYN and one of the area's first female surgeons. After 5 years of serving her hometown, she's back in the Auburn Opelika area with her husband, her 2 young boys, and big porch sitting energy. I love that. She's bringing expert care, deep heart, and southern charm to women across East Alabama. Dr. McInnis, I'm gonna call you Emily here, but Dr.
Yes,
McInnis, I'm so excited to do this. We're also neighbors,
yes, we
so
are.
The commute was
Oh,
easy.
it
I
was
love that for
super easy.
us.
Yeah.
I'm so excited. We have so much stuff I want to talk about. But first, I just want to get a little background. Like, what's it like being back in Auburn, raising your kids here? I hear people do that a lot, come back
hmm
after the fact with their kids. So, what's it been like so far?
It has been great. And of course, I went to undergrad here at Auburn, like she said, and really never thought that I would end up back in Auburn, but did a little Southeastern tour, went to South Carolina, Mississippi, back at home for a while. And then this opportunity just presented itself. And I'm so glad that we made the move. The boys love being in the same town as Albie. They think it's
Oh.
great that he's everywhere we go. They've learned the fight song. They think that everything Auburn is just the coolest. So we have had a very good time as a family, establishing in Auburn and just planting roots here and hope to be here for a long time.
I love it. It's so exciting. We moved to Auburn before we had our daughter, and I loved it for a different reason then. We were
Mm-hmm.
younger, right? But raising a family here
It's
is,
special, isn't
it
it?
really is special. It's such a sweet little town. Okay, well, there's so much that I want us to dig into. We're not going to have time to dig into everything, but I do want to ask, and for anyone listening that I haven't said this before, I have a history of labor and delivery. I was a registered nurse in labor and delivery. So I'm almost like fangirling having an OBGYN of like, oh my God, I want to talk like standing orders and
Uh-huh.
how do you do all the things because it's been so long. But I really want to dive into like some of the most frequently asked things that you come across in your practice, whether it's like pregnant, before pregnancy, postpartum, like any of the most common things that you can kind of touch on just to educate myself included.
Yes, and I think, I'm so glad that you had me here today for this because I think a lot of times in all ages, people are just nervous to ask certain things or to
Mm-hmm.
bring certain topics up to their OBGYN. And I just want people to realize that it doesn't have to be taboo. That's what we're here for. And part of the reason I love my job is because I get to work with women from, their adolescence when they're starting their cycle for the first time, through having babies, through menopause, through hysterectomies. So I get to follow them through every phase of life. And I love that continuity of care. I love getting to know my patients. And I love when we develop that relationship where they feel comfortable that they can come to me with these issues.
Mm-hmm.
But there are a few topics that I do get asked about probably the most often that I wanted to hit on. First being the hot topic of menopause.
Yes.
And I think that there are a lot of people that don't realize that as a general OBGYN, I can see you for menopausal symptoms and treat those. And what that looks like for each individual person is a little bit different. But, for the past few years, it's really kind of come out into um, the light that this has been an understudied area of medicine.
Mm-hmm.
And as a female, it's like you want to push this because they study medications with men that go through these changes, and that's highly studied and highly regulated. But then when it comes to women, we don't get the same attention,
Yeah,
and it's just not fair.
I know.
So now that it is being pushed into the spotlight, I'm really excited about it. I feel like there's some really good things coming out in the next few years to
Mm-hmm.
be, even more treatment options. But, I really think that we went through a time period in the early 2000s where there were some studies done, and some of the studies in the media that, in my opinion, were flawed, scared people from using hormones. So
Mm.
you probably hear your mom, your grandmother talk about, oh, don't use hormones. They're bad for you. They're not
Like the
safe.
estrogen.
Yes.
Okay, yeah.
So
I've heard that.
estrogen, testosterone.
Mm-hmm.
And now that they have started to look into those studies and redo them, they're realizing, hey, these aren't so bad.
Mm.
Not only are they not bad, but they can really help people out. They make you feel better. And there's some health benefits to them too.
Mm.
And it's safe. So the short answer to that is yes, they are safe. And of course, that's individualized. I would want to talk to you about your personal history before starting anything. But if you're under the age of 60 and you're less than 10 years from hitting menopause, then I think it's definitely worth a discussion. And I would love to talk to you about that. And it's not a one size fits all approach, and that's what I think is another misconception. We have so many ways to treat people with hormones. We have estrogen in the form of pills, creams, lotions,
Mm-hmm.
troches. We have pellets. We have everything.
You have
Um,
suppository?
yes.
Yeah.
hmm
Mm-hmm.
And I think vaginal estrogen is actually one of the most underused. I think everyone should be
Mm-hmm.
on
I've
that.
heard that before.
It's safe. It doesn't even get into
Mm-hmm.
your bloodstream. Very, very little amount is absorbed. So even my patients with breast cancer can use vaginal estrogen.
Wow.
Um, and I always use this analogy with people that all those studies that said that things were unsafe, and yes, there are certain populations that should not use
Sure.
hormones, but with anything in life, you've got risks and you have to think about your risks and benefits, right?
Mm-hmm.
So if you have not had those certain medical conditions that qualify you for hormone replacement, then you have to think about it like when you're waking up in the morning and you're getting ready for work. You can either walk to work or you can drive your car, right?
Touche.
So,
Work smarter, not harder.
right now, when you
Mm-hmm.
get in your car, you know that there are risks.
Yeah.
You could get a ticket, you could get pulled over, you could have a car wreck. And while you know all those things, you're certainly not going to walk to work
Mm-hmm.
because
It's a risk you're willing to take.
right,
Yeah.
that's a risk you're willing to take. So, same thing with hormones. Are there risks? Of course, there's risk with
Sure.
anything. But if you think about how much better it could make you feel, how it could improve your daily life, your relationships,
Mm.
um, I think it's worth it for most people when they consider it that way.
So I want to give like a for instance to see how, because I was just texting with a girlfriend yesterday. She's the same age as I am, about to turn 39, and she is having hot flashes
hmm
galore.
hmm
And to me, on paper, I'm like, we're still like 25. That's like hot flashes. That's not normal, but normal versus common, right? I'm not sure
Right.
like where the differentiation would be, but what would you say to someone who's like, because she's not going to go to her OBGYN, she's just going to complain about it. Well, like most
Right.
of us would,
Yeah.
right? Like we're just going to complain and fuss about it as
hmm
often as possible, but not knowing like what questions to ask or that there is something that could help. Is there something that would be beneficial in that scenario of like, I don't feel like I'm premenopause,
hmm
which I guess maybe we are, but the hot flashes, how can those be
Yeah, and
helped?
so the first thing to discuss is you said the word is this normal, and I
Yeah.
get that all the time. So I think
Mm-hmm.
people there's no definition of normal.
Sure.
So if it's enough to bother you, then it's worth talking about. So, it's hard to say is this normal or not.
Mm-hmm.
But if her symptoms are enough that she thinks, hey, we need to discuss that, then by
Mm-hmm.
all means, I would love to have a discussion.
Yeah.
And when when you start having those symptoms, of course, it can be for many different reasons. It can be for different stress, it can be different metabolic issues, it can be thyroid issues, but it can also be early menopause.
Mm-hmm.
And I see menopause anywhere from in the 30s to the 60s. So again, average age is like 51, but everybody's different. So
Mm.
you might be going through early menopause. I might have somebody that doesn't go through menopause and stop cycles till they're 60.
Wow.
So there's no normal. There is just a, hey, let's have a discussion about it. Let's check some labs. Let's talk about your cycles. Let's talk about your symptoms and go from there.
Now, if she were still on birth control, like an IUD, and I'm not sure which kind, would that kind of prevent her from having early menopause, like just kind of stall that out, or would she still have those same symptoms? I'm not sure if she's on birth control, but just
Right. Well, and with the IUD, not necessarily because it's progesterone only,
mm-hmm.
but I love having my perimenopausal patients, so in their 40s or
Yeah,
50s, on birth control pills because
mm,
birth control pills have estrogen and progesterone, right?
right.
So, especially if they still have a uterus and I need to protect that endometrium with progesterone, the birth control pills are actually giving them that estrogen supplementation that they need so that their body doesn't go through that, quick
Mm-hmm.
decline, which is what causes the vasomotor symptoms, the hot flashes, the night sweats, the mood swings. So it's almost like it takes them through those years.
Gotcha.
And then when they hit 52, 53, and they're past that average age of menopause, then we start weaning down on the dose. And usually people do very well doing that.
So is it easier to do the birth control versus separating the two hormone replacement therapies and doing it that way, just because they both kind of knock out a couple of
Yeah, and I
birds with one
wouldn't say
stone?
it's necessarily easier for the patient it is because it's one
Just
pill
one
instead
pill,
of
yeah.
two. But they actually do make some bioidentical combined medications now. Bijuva is one that has estrogen and progesterone together.
Okay.
So they do make different formulations. But what most people don't understand too is birth control pills are actually a higher dose
Mm,
than our hormone replacement therapy.
I did not know
Yes, they're
that.
stronger. So if you have somebody that say is in their 20s or 30s, they need a higher dose of estrogen than a 50-year-old would.
So interesting.
So if I have somebody that is on that, I'm weary to change them to a hormone replacement
Yeah,
dose
because
and
it's not gonna be
right
less than, yeah.
till they're past that age of menopause. So again, when they're 51, 52, we consider tapering it down to a hormone replacement dose of estrogen, but that
Mm,
would be changing from a birth control pill to a regular estrogen pill.
mm,
But when they're taking those birth control pills, unlike in reproductive years, you skip that placebo week. So you just
yeah.
want to take the medicated pills.
So you continue, you start your new pack when
When
you
you
would
hit,
typically take the bleed week, if you
right.
will. Okay. All right, cool.
And we have to write a prescription different so that
You
you
get them
obviously
filled
get
more
enough.
often?
Yeah.
Okay.
Yeah.
Interesting. I did not know that.
Hmm.
Okay, so on the conversation of like that age range, cancer prevention is something we talked about before we
Yeah.
started recording. So, tell me what that looks like for common questions.
Hmm. So a big question I get, of course, is from moms that are they're
Mm-hmm.
like, "Hey, when does my child need to start coming to see you?"
Mm-hmm.
And again, there's really no right answer to that. Now, Pap smears, which are cervical cancer screening, starts at 21.
Has it always been that?
No, it has changed. It used to be when you became sexually active, or
Yeah.
I think at one point it was even 18, but it is 21 now.
Interesting.
Hmm. And we typically do it, and really it's based off of how often insurance will cover it. But we
Sure.
usually, at my practice, is to do it every other year.
I do remember when it used to be once you were sexually active or you were telling people you were sexually active
Right.
and you were
Yeah.
okay with going, right? But then it was every year. And
Hmm.
now it's like that every 2 year thing is kind of hard for me to stay on top
Hmm.
of because before it was just like you're going to schedule the next one while you're there. And,
Hmm.
so
Well, and the guidelines actually even say every 3 to 5, but I have a hard time with that.
why?
They say that you have to weigh the cost of pap smears and the
Sure.
benefit. So after doing studies on that, they've pushed it to 3 to 5, which to me is a big, that's a big gap too.
It's a very big gap.
So I'd err on the side of caution with
So what
everything.
if the patient is like, let's just say somewhere in their 20s and highly sexually active with different partners? Do you
Mhm.
then recommend more recurrent, like quick, more consecutive pap smears or different testing?
Not with the pap smears. I do, if people are sexually active, then I do think that a yearly STD
Mm-hmm.
panel is
Mm-hmm.
beneficial.
Yeah.
Just because you never know,
Mm-hmm.
and it's better to get checked and say it's negative than to not get checked at all.
Mm-hmm.
But the Pap smear is for specifically cervical cancer screening, which can be affected by HPV, which can
Mm-hmm.
be transmitted sexually. The good thing about cervical cancer is it is very slow spreading.
Mm.
So it's something that if you have an abnormal or mildly abnormal Pap smear, it could take 10 years before it actually became cervical cancer.
And you can have an abnormal and then not have an abnormal.
Correct, because it's a virus. HPV is a virus, and there are several different strands.
Mm-hmm.
And it's just like the cold or flu. If you have a healthy immune system, 8 out of 10 women at some point have a
Mm-hmm.
positive HPV test.
Mm-hmm.
Very common.
Yeah.
Most of the time, if your immune system is working and you're healthy, next time you get a PAP, it may be completely normal.
So, and is the recommendation if you have an abnormal, you get the colposcopy like right thereafter?
If it is a high risk strain of HPV. So now
Oh,
we do co testing with a pap smear. So you get your cytology read and then you get your HPV test. And if the HPV test is a high risk type, so 6, 11, 18, 45, 32, there's several different strands.
and they won't be reading that
No,
part, right? Yeah,
no.
that's
But if it's high risk, then we will call you and we schedule a colposcopy.
okay.
If it's not high risk, then we just repeat it the next year.
Mm,
Hmm.
fascinating.
Yeah.
So much has changed.
And I really think in the future they're going to flip that. They're doing some studies now that show that we don't even need cytology. We just need HPV because that's the most important.
So basically saying if it's abnormal, you always get a colposcopy or
Just saying that if you have a high risk HPV, that you get a
gotcha.
colposcopy. But say your cytology shows mild
There's
gravy,
no
but your
differentiation.
HPV is
Yeah.
negative, you wouldn't even need it.
Oh, gotcha.
Hmm.
Interesting.
Yeah.
Okay, so what about breast exams,
Yes.
mammograms, and such?
I am a huge mammogram fan. I think
Yeah.
that at 40, people need to start doing that yearly.
Mm-hmm.
And also, mammograms are great, but they're not 100%. And if
Mm-hmm.
you feel like there is something abnormal, please let us know so that we
Mm-hmm.
can do an exam.
So, like, give us for instance of what abnormal would feel like.
So, for instance, I've had a patient this year actually that had a normal mammogram, had zero indication of anything in, I forget which breast it was, but in her breast. And she came in and she was like, "Hey, I've felt this lump, and it's been there for a couple weeks, and a couple weeks is not a long time, right?"
Mm-hmm.
And she said, something's not right. I don't know how to explain it, but it just doesn't feel right. And I was like,
Mm-hmm.
"Was it painful?" And she said, "No, it's not painful. I can just tell it's there." So I did an exam, and sure enough, it was a mass. Sent her for mammogram, and she got diagnosed with breast cancer. And
Wow.
thankfully, they caught it very early.
Yeah.
So they were able to do surgery, and she's doing well. But, what if she wouldn't have come to tell me? Her next mammogram wasn't until, you know, 8 months later.
So, was she doing monthly breast exams, like self exams, or was she just that in tune with her body that she could tell?
She said she was just in the shower and felt something was off.
Wow.
And she said the first week she was like, "Oh, maybe it's just that I'm on my period, and so
Mm-hmm.
it's a little tender or sore." But then it never went away, and it just got bigger and more bothersome.
Mm-hmm.
And then she came in to see me, and I'm very glad that she did, and she listened to her instincts there.
Mm-hmm. I can remember in nursing school when we did this area of education, it was one of the things they were recommending at the time was to do it just in a way that you would remember. So, like the beginning or the end of your cycle, just because
Hmm.
you were always going to have that unless you were pregnant. And so it gave you kind of a marker to go by and like
Yeah,
to
that's
put
a
your
great
arm
idea.
up and like to, and there's so, I think
Mhm.
there's a lot of education online now, whereas there didn't used to be.
Yeah.
So I think at the end of the day, as long as you're familiar with your body and like if something feels
Hmm.
off, I got my first mammogram at 35, and
Okay.
I was just going through like this very like deep health journey, if you will.
Hmm.
And so I just called the place, the testing I don't even know
The
what it's called here.
diagnostic
Yeah, the
imaging center.
diagnostic.
Yeah.
And I was like, hey, how's it work to schedule a mammogram? And they looked up my insurance. Turns out
Hmm.
I get one free per year. And at 35, I could go and get a mammogram. And I was like, sweet,
Yeah. And
give me a
some,
baseline.
yeah, some insurance companies, pending your family history and personal risk factors, will cover them at 35.
So for me, I don't have a family history, knock on wood, not that I
Okay.
know of.
Uh huh.
But I have implants. And so I was having some pain sleeping on my side that I was just chalking up to my implants being uncomfortable the
Hmm.
way I was sleeping. And it started to wear on me of
Yes.
like, is it the implant?
Hmm.
I don't know. Let me double check. And so that was part of like my whole health journey of let me just double check.
Hmm.
Let me just make sure.
Which again, back to the definition of normal, there is no definition.
Yeah.
So if you think something's wrong, it's always best to have it checked.
Like why not,
Right.
right? Like what's the harm, especially if your insurance covers it, which
Right.
I was lucky that it did.
Hmm.
Um okay, I love all of this. I'm trying to I know that hormone kind of going back to the hormone replacement for just a moment, like
Hmm.
the testosterone is such a huge thing for women. The
Yes.
way I hear it more often than not is for sex drive
Hmm.
and well, libido. So men have testosterone replacement, and so do women. Most of the time,
Mhm.
women do the pellets, men can do
Mhm.
pellets. I have a little bit of confusion on the difference between the two dosing.
Mhm.
But do you see where that is a huge benefit, or is it still in the early stages of kind of
So
practicing?
I do see that patients have benefit from it.
Yeah,
And again, it's frustrating because, like you said, testosterone has been studied for men
everything has.
for
Yeah.
erectile
Yeah.
dysfunction and all these medications for years, but no attention's been put on females.
Hmm.
And, you know, women's libido is just as important as men's. So I think that it's great that it's being put in the spotlight. And it's also frustrating that the FDA has cleared all of these testosterone products for men, but not one is cleared for women. And so right now we're using testosterone off label until they do enough studies to make it to where it is labeled as a low libido treatment.
Okay. So, but how long do you think until you're there? Like, no telling.
I'm hoping it's not long,
Yeah.
but I mean, they've been working on this for years now. But I really do think that now that it has become, especially with social media, it's become
Yeah.
more of a hot topic.
Yeah.
And so they're getting pushed to do these studies. But again, there's so many different forms. There are pellets,
Mm-hmm.
there are lotions, there are creams, there are
Mm-hmm.
troches, there are several different ways you can do it. I personally use a compounded testosterone cream for my patients when they present
Mm-hmm.
with this problem. And again, everybody's different.
Yeah.
Everybody's receptors are different. Everybody's hormone levels and their normal are different.
Mm-hmm.
So I always explain to people the risk and benefits. If they want to try it out and see if it helps with libido, we do it. And I usually do about a 3-month follow up, see how people are feeling. Most of the time, they can tell at least a little bit of a difference.
Do you do pellets?
So I personally do not, but two of the
Mm-hmm.
physicians at my practice do
Does
do
insurance
pellets.
typically cover that, depending on the case? Yeah. So that's the thing, is the insurance covering, which makes it really hard for a lot of people to get that sort of treatment because it
Yeah,
is not cheap.
it is not cheap. And speaking of, we do progesterone, estrogen, and testosterone in different variations.
Mm-hmm.
And we do all of those compounded.
Mm.
And we have a great relationship with a pharmacy that's local that helps us out. We actually have a whole menu of hormone replacement items now.
Awesome.
We have a facial moisturizer with estrogen.
That's
We
awesome.
have a product called Screen Cream that is for orgasms.
Scream
Screen Cream.
cream.
Who knew?
I love it. I've heard of the O shot too. That's a big
Hmm.
one that I've heard a lot about.
We have the estrogen suppositories, estrogen creams, testosterone creams. We have we call it Gale cream. It's for pain. It's got gabapentin, lidocaine, and estrogen in it.
For painful intercourse.
Mm-hmm.
Okay. What is
Yep.
that called again?
We call it Gale cream just because of
Gale cream.
it's got gabapentin, amitriptyline, lidocaine, and estrogen. And it helps
Okay.
with people that have vaginismus or really
Mm-hmm.
tight pelvic muscles.
Which is way more common than most people would
Mm-hmm.
think. A lot of people just, I've seen it from experience of coaching dynamics of they just think their body's broken and
Oh,
they
right.
don't
Yeah.
go to ask questions.
Mm-hmm.
They don't talk about it. So they think it's just them, but it's
No.
way more
Yeah,
common.
it is way more common. And it
Mm-hmm.
can be for several different reasons. I mean, some people have had, sexual trauma in the
Sure.
past. And so it just makes them terrified of sex. And
Mm-hmm.
it's more of a mental thing.
Yeah.
Some people truly have hyperactive vaginal muscles,
Yeah.
levator muscles. And so we can train those. We can use these creams, these topical creams to help.
Mm.
Dilator therapy. We have pelvic PTs in the area that are great with working with our patients that have pelvic pain issues. But yeah, all of these compounded creams and medications are so beneficial, but they're not covered because they're
Mm-hmm.
compounded. So
Yeah.
until the FDA clears some of these, hopefully in the near future, that does
Mm.
continue to be a problem.
Yeah. And, hopefully sooner rather than later, but
Um,
it's out there if
it
you
is.
can afford it. And
Yes.
hopefully one day it'll be insurance covered.
And we're talking like $30 to $50 for a jar. So it's not horrible.
Yeah, yeah. Yeah. Oh, yeah. Definitely still get it checked out
Yeah.
for sure. Um, and there are so many places that are popping up
Mm-hmm.
everywhere of these anti-aging clinics that offer all that stuff. And I think that's great, but it's also typically a lot of those places offer like memberships.
Yeah.
They kind
Mm-hmm.
of cover the cost, but then they're not always in small cities. And I think people forget to go to their OBGYN. They just see these anti-aging and it's like,
Right.
hold on, wait. You don't even know those people sometimes. Start with your regular
Right.
doctor and see if they provide it and then maybe explore other options if you have to.
Well, and because we know your history, right?
Yeah,
So I would much rather go to somebody that knows
for sure.
my health history, my surgical history to talk about these kind of things. I just think they truly don't know that we offer it. And so,
Well, and then you have like the uh, crossing of different providers treating you without knowing how the other one's treating you, which is a
mhm,
very common thing. But typically
mhm,
that happens later in life when things are starting to kind of go,
yes.
a little haywire.
Hmm.
Um, so yeah, I love knowing that you guys are offering that. I think that's
Yeah.
fantastic.
Hmm.
One thing I really want to dig into, and we talked about it earlier, was like the effect of social media on
Yes.
women's health and what people think
Hmm.
is like we were talking about normal versus common, things like that. But specifically with like pregnancy
Yes.
and uh birth and all of those things. Have you seen, because I'm sure you have seen like the rise and all of these shifts happening in real time.
Hmm.
What are some of the biggest misconceptions that the internet is telling us?
I'm glad we're talking about this because it is frustrating. We go to 12 long years of medical school
Mhm.
and residency is just, I mean, it is a hard time in life,
Brutal. Yeah.
brutal. And you get out of this training and then you pass all your boards. And one of my biggest accomplishments is, you finally pass your oral boards, that last board exam. And it's like,
Mhm.
wow, I feel so accomplished. Like I have learned a lot.
Mhm.
And then you get on social media and you see where, people just think that we're out to get them,
Yeah.
that we just want everybody to have a C-section. And that
Mhm.
could not be farther from the truth. Like
Mhm.
we are, speaking for myself at least, are the biggest patient advocates.
Mhm.
I am all for a patient being able to experience labor the way that they want,
Yeah.
to be able to, hold their baby and have that nice vaginal birth that everybody dreams about, the
Mhm.
the birth story that everybody paints a picture of. But at the end of the day, the truth is it's still medicine, and
Mhm.
medicine does come with risks.
Mhm.
And sometimes it changes that story that people have in their head of how things are supposed to look.
Yeah.
And it's not by fault of theirs, it's not by fault of mine.
Mhm.
But I think social media has made it really hard for us because we truly just want safety for our moms and our babies. And I think sometimes that doesn't get portrayed in the right light.
Yeah.
I have women that come in with birth plans, which is fine. We love that.
Mhm.
We usually have a conversation before we get
Sure.
to labor and delivery to talk about specifics that you want. A lot of patients don't want epidurals or pain management, and that is completely fine. They want to push
Mhm.
in different positions, completely fine.
Mhm.
Intermittent monitoring, that's fine too.
Is that way more common now?
Yes.
That was not
Yes.
normal
Well, and that's
when
the
I was
thing, right?
when I was working. Yeah.
Over time, things have shifted so much.
Especially like the oh God, what is it? Where they're not even hooked up with cords. They have like
And like
remote
the wireless.
monitoring.
Mm-hmm.
Oh my God.
Mm-hmm.
Um how is it now with like food and liquid? Because we would keep everyone NPO, which is like no food, no water type of thing. And
Yeah.
everyone hated us, right?
Oh, yeah.
But I was
Mm-hmm.
always like, you don't know if you may have to have major surgery at some point.
That's
And
true.
so this is a huge caution.
Right. And it's really more of an anesthesia rule than ours, I
Mm-hmm.
would say, because if you do end up in an emergency section, you don't want a belly full of food
Mm-hmm.
on you.
Mm-hmm.
So
Mm-hmm.
we usually, when we're doing inductions, I tell them they can eat dinner, eat until midnight. And
Yeah.
at midnight, I usually tell them just to hold until the next morning. We see how things are going.
Well, inductions are different though, but like when they're
Yeah.
laboring, is that something that you anesthesia is more lenient with now, or that is still
If
kind of commonly?
if they're active labor, then they
Yeah.
can eat.
Okay.
No, I'm
I
fine with
mean,
some like, clear fluids or something to drink. But
mhm.
yeah, if you're in active labor,
See,
you
and I
know.
sometimes I think like how much of it is just programming that I got through my routine of how I did it back then or how the doctors around me did
Mhm.
it. But for me, because I saw how easily and how quickly things could turn, and you could be in the OR and you
Mhm.
could aspirate, right? You could throw up, what, sorry for the, gory
No,
details, but
it's
it
the
can be
truth.
really, really dangerous.
Mhm.
And so I'll see some people who will, have home births and stuff, and I'll see them eating while in active labor, and I'm like, oh my gosh, like
It's terrifying.
I
Yeah.
I couldn't do it. Like I had to deliver at a completely different hospital because I did not want to micromanage my
Mhm.
delivery.
Mhm.
But stuff like that is it's really hard for me to get on board with that. Also,
Yeah.
like and this is not to knock anyone who's done home birth or water birth, because if you do it the right way, I'm sure it's a great experience. And I don't know though, but it scares me. It really, really
Right.
scares me. Like when I see people home births specifically, I'm like, that water is so dirty. That water is so dirty. That's the first thing I think of.
Yeah.
And I'm like, how much of that is just me being like anal, right?
Mhm.
About the cleanliness of it and stuff like that. And
Mhm.
um, yeah, and I've seen too with clients of mine who have been pregnant and really locking in on one doctor. Like that
Mhm.
doctor has to be there when I deliver, or else I'm not going to deliver, and all this stuff. And I'm always like, that baby's coming. Doesn't matter
Right.
who is in the room, that baby's going to come out. Yes, you need
Yes.
to make sure that if something were to go haywire, that you have someone you trust to make decisions on your behalf, things of that nature. But if it is a textbook, beautiful vaginal delivery, that baby does not care who is
No.
in that room.
No. And we do have some patients that, find one of us that they really want to
Yeah.
deliver. And if it works out, that's great. But I always
Sure.
tell people, I'm a mom too. I have a family at
Yeah.
home. So if we can schedule this and it happen on the day that I'm there,
Mm-hmm.
great.
Yeah.
But if this baby comes in the middle of the night, I can't promise it's me. But one of my
Yeah.
partners that I trust with my life would take care of
Do you
you.
guys like rotate through the
We
doctors
do.
in the practice? Yeah, I always thought that was a good
Yeah.
practice to have.
And we all practice very similarly. So we all have
Mm-hmm.
the same ways of managing certain things. But yeah, that that way of or that mode of OBGYN has changed over the years too, because I feel
Mm-hmm.
like in the old school way was that you were just on call all the time
Mm-hmm.
and people would come in no matter what time of day or hour it was. But now you've
Mm-hmm.
got a lot of women that are OBGYNs that have
Mm-hmm.
children at home, and it's made it harder. So the call schedule rotation has become popular. The hospitalist system has become popular to have backup.
Mm-hmm.
And I would say most hospital systems, if not all, are really working by that method now.
That's great. That's great for that work-life balance, because
Yes.
I can remember I always worked night shift.
Mm-hmm.
And boy, I hated to call those doctors, especially the ones that I knew had young kids at home. Well, the
Yeah.
moms, not the guys, because there
Mm-hmm.
was always, typically they were in a like a break room of some sort. But I could always hear like kids in the background of some of
Yeah.
the OBs that I
Uh,
worked with, and I'm like, I'm so
yeah.
sorry,
Uh-huh.
but my standing orders don't give me anything for
Yeah.
this particular instance, right?
It's part of it, but as long as you have that balance, like I was on call last night and same thing. I was trying to wrangle my two to get in the bath, and they
Mm-hmm.
called me about a patient, and I was like, I'm sorry, you can hear my children yelling in the
Yeah, yeah,
background. It's bath time.
yeah,
So, I mean, I think people have just kind of learned that that's how it is. And thankfully, I do have the balance that I can be at home and have a hospitalist that's there to help
mm-hmm.
cover for emergencies. So, I think that's important.
Yeah, I
Hmm.
think that's great.
Yeah.
Really, really great. How common are TOLACs now? So trial of labor
Hmm.
after cesarean, for anyone who doesn't know that.
Yeah. I think myself and all of my partners we will all allow TOLACs or,
That's great.
yes, trial of labor after cesarean. Of course, as with anything in medicine, we go through risk and benefits. So if
Mm-hmm.
you've had a cesarean section, at your very first visit, we're going to ask you why you had that C-section. Was it because your baby was too big? Was it because the
Mm-hmm.
pelvis was too small? Um,
Things that don't change
Things that
over
don't change.
time.
Yes,
Yeah.
you cannot change anatomy.
Mm-hmm.
Or was it because your baby's heart rate dropped
Yeah.
and you had to have an emergency section, or you had a cord prolapse,
Yeah.
or baby was breech in a different position? Because
Mm-hmm.
those type of things are, telling me that maybe there is a shot that this would be successful.
Yeah.
Now, I'm not saying even if you had a C-section because of your, pelvis size and shape, or baby was too big, I'm not saying you can't try, but your
Sure.
chances are going to be lower, especially if this current baby is larger.
Mm-hmm.
Um, and then there's always that 1% risk that is there of a
Mm-hmm.
uterine rupture, and we always tell
Mm-hmm.
everybody that.
Mm-hmm.
And it's very small, but it's there,
Yeah.
and we have seen it happen.
Yeah.
So I don't want people to forget about that. But as
So
long as they're okay with that risk.
yeah. Well, and there's risk for everything, right? Just getting pregnant in and of itself is a
Oh, yeah.
risk.
Yeah.
So for Tolax, does each doctor at your practice have different standing orders as to how that works? I remember when I was working at the bedside, some doctors would augment, meaning like
Mhm.
add Pitocin in if they were already laboring, but they'd have to be on the premise if they were augmenting. Otherwise, you could come in
Yes.
and like labor naturally without any sort of extra push, Pitocin, or anything like that.
Yeah,
Is
there's
that
some
still kind of the
extra.
standing?
Yeah, there's extra rules
Yeah.
that are present for Tolax. Now, I will say personally, I don't think everybody has this rule per se, but I prefer that my Tolax patients have an epidural
Mm-hmm.
just
Just in
because
case.
you never know what's going to happen.
Mm-hmm.
And say you're in that 1% that has a uterine rupture, and all of
Mm-hmm.
a sudden your baby's heart rate goes down and you're bleeding. If you don't have pain control,
Mm-hmm.
not only do I have to put you under general anesthesia, but
Mm-hmm.
that takes time, right? That is a waste of precious seconds
Yeah.
that we have to get to your baby.
For safety, yeah.
If you have an epidural, I can just roll you back and we can get started because you're already numb.
Yeah.
So I don't think people think that through really. They just think
Mm-hmm.
we're being mean and want you to have an
Mm-hmm.
epidural, but that there's a reason to that.
Yeah.
And every second counts when you're in those emergent situations.
Mm-hmm.
But as far as the rules, yes, we have to be in house with people that are doing a Tolac, and the Pitocin is just much lower dose,
Yeah.
slow and steady.
Slow and steady. I love that. I had a friend that was doing, she had secondary infertility, and for her first pregnancy it was a emergency C-section. And so she had already gone through all the secondary infertility stress and then gotten pregnant. And then it was so important to her to have that vaginal delivery experience that she went to. She lived in Atlanta, multiple practices, just trying to see what they would actually like give her as an option, because some people are like, nope, we just don't, for liability reasons. We just
Mm-hmm.
don't even give the option. You're a new patient. We don't have any background with you,
Right.
so on and so forth. She did finally find someone because it was that important to her. Most people don't take it that far, and I'm super
Right.
proud of her for, because she got
Yeah.
her experience that she wanted, but she
Mm-hmm.
knew it was possible, that it was not going to turn out the way that she had wanted, but it was like she could not rest unless she tried everything. And I love that for her.
Yeah, me too. And there is nothing more satisfying to me than a successful VBAC. Absolutely love it.
Yeah.
And it all depends on, I don't know where she was looking, but the hospital size, if they have
Mhm.
in-house anesthesia. So
Mhm.
legally, some of these smaller hospitals just can't offer them
Yeah,
because
that's true too.
it's
I
not
didn't think
safe.
about it.
It's not that they don't want to. And I think that going back to social media, I think that's where the misconception is we
Mhm.
have to put patient safety first. So if it's a small hospital that doesn't have a 24/7 anesthesiologist that's in-house,
Yeah.
or doesn't have availability of an OR quickly,
Mhm.
then it's really not safe for you to offer them.
Yeah.
And it's not that, again, we're being mean or trying to take something away from people,
Sure, yeah.
but we certainly don't want that middle of the night emergency that we can't do anything about. So some places can't legally offer them, but thankfully at East Alabama, we have VBACs all the time.
That's awesome.
Yeah.
That's awesome. I think that a lot of people forget with obstetrics specifically, you have two patients.
Mm-hmm.
Like
You do.
you have two patients. Like if
All
you're
the
just a
time.
gynecologist, right? That's a different scenario. But when you are actually like you have two patients and one of them cannot talk to you.
Right. And people forget like the pressure of our jobs is real and it never goes
Mhm.
away. We
Mhm.
always have two patients when I'm
Mhm.
on a call shift with
Mhm.
each
Two
room.
sets of vitals.
Yes.
Yeah. Mhm.
And every decision I make could change, both of those patients' lives, right?
Yeah.
And so it's a constant pressure.
Mhm.
And, it's easy for people on social media to not understand that pressure and not see it,
Yeah.
but it is present. And we just have to constantly, be thinking about plan A, plan B, plan C, all
Mhm.
the way down the line. And that's just how our minds work. And it's exhausting, but
But that's why you're the professional, right? Like that's why you hold the degree and the title, is because you can see that entire picture.
right.
And social media is not proper education on these scenarios. Like, yes,
Correct.
maybe you see a story that ended up really great and that's wonderful for them, but that is not to be taken as
Mm-hmm.
medical advice in any way, shape, or form. But
Right.
also, I think in my experience from the nurse perspective, so we had a very small period of time in nursing school where we even talked about women's health. I think it was like half a semester,
Mm-hmm.
and I think it was doubled with mental health as that same, the other half. So it was very, very small that we got. Also, mental health should be a much bigger
Oh,
module, so to speak.
absolutely.
But I remember so much of that happened on the floor. So much of it happened. All of it, really. Like we couldn't do cervical exams and clinicals, things like that for good
Mhm.
reason. But all the things you learned in real time, like experience driven.
Yes.
And there was in nursing, well, for labor and delivery, typically there's a triage scenario where you're
Mhm.
coming in to make sure that you are in labor and in fact need to be admitted. It's like the emergency room of
Right.
labor and delivery. And I remember I thought I knew a lot until I went to
Until you got
triage.
there. Yeah.
And triage is typically, at least in my experience, was the most understaffed part of labor and delivery. Like typically they had one or two people and you
Mhm.
could get overrun very quickly. But because they weren't admitted and you weren't monitoring mama and baby as closely, like the ratio was different then
Mhm.
anyway. And I remember being terrified.
It's a
Like
scary
because you
place.
don't know what
Yeah.
it's very similar to emergency room,
Mhm.
except emergency room has a wider range of things that are going to happen. But there was always because they'd go through the emergency room and then come to triage.
Mhm.
And so we'd have so many scenarios of like, guys, you did not have to bring her up here. Like you knew she wasn't in labor, so on
Mhm.
and so forth. But
If
there were,
people are pregnant though,
oh yeah, they don't touch
they're
them.
terrified.
Oh yeah, you go straight to triage. Do not pass go. Go immediately. We do not
Mhm.
want the liability.
That's right.
Um, but I used to say when I would talk about what I did, and for my husband Colby, he's like, I'm never gonna know what it's like for you at work, and I'm like, you just wait. And so when I went into labor, I was like, over here, buddy,
Uh-huh.
all the things you wanted to see what I do, and he ended up actually delivering our daughter.
No,
Um,
I let dads do that all the time. It's so much
I
fun.
think it was Dr. Harris
Uh-huh.
had a bunch of students, and my doctor didn't make it in time because everything happened really quickly.
Mhm.
And I was an induction, but still things progressed really quickly.
Mhm.
And so he had all his residents. And I, being the nurse, was like, bring them in,
Yeah,
let them
they gotta
learn.
learn.
My husband got so upset with me because I let the resident came in and was like, I would really like to start your IV. And what? You want to learn how to start an IV? I have never heard of such. Come on, I'm gonna walk you through it.
Oh, that's funny.
And
You probably
Colby,
made his day.
oh my God. Well, he blew like two or three veins, and Colby's like standing over at this point, like, I think that's enough. Can the nurse? And I'm like, he's got it. And so I'd be like, pull it back, thread it. It's right there. And I'm like walking him through it. And I'm like, I'm just so impressed that you want to learn
Yeah.
because when I'm working, none of our residents care about starting an IV. I'm
Uh-huh.
appreciative that you want to learn this. And so I want to do this with you. Um,
That's very kind of you.
but I love it.
Yeah.
So that's like the RN in me is like we teach,
Mhm.
right? That's the basis of how I saw it anyway, is like teaching them,
Mhm.
also advocating and all of that stuff.
Well, it's hard to learn women's health because one
Yeah.
issue that we run into with our medical students is, and I understand, but patients are, it's a very vulnerable time. They're there for
Mhm.
a pelvic exam and they don't want a
Mhm.
student learning on them or doing their
Yeah.
first pap smear with them or delivering their baby. And so it's really hard as a student and you
Mhm.
don't get a lot of hands-on experience until you are in residency.
Yeah.
Um, so yeah, when I have students, I try to keep that in mind and discuss with my patients beforehand, like, hey, this is what we're doing. I'm going to be
Mhm.
right there with them, but because it is hard. Um,
I always saw it and very different for the resident versus like new nurse perspective. But the nurses that I would shadow once I had the job and was on the floor, they would always go to the patients that it wasn't their first baby because more than likely they're going to be way more accepting to you
right.
coming in here and wanting to learn and so on and so forth.
Yes.
You coming in there with probably a couple of people might be a little bit more daunting depending on what's happening. But that always seemed to work pretty well.
Hmm.
And cervical exams were the hardest thing, right? Because everyone's body is pretty different.
Hmm.
Cervix can be in different locations.
And it takes a lot of practice to get a
Well, and
cervical
it's
exam.
like, how much practice do you get,
Right.
right? You can only check so many times and have
That's
so many.
right.
And so it is a learned skill.
Hmm.
And I remember there were a couple of doctors where they'd be like, check before me,
Hmm.
right? Like
That's
if
what I
you,
typically do too.
or
Yeah.
if you're in full active labor, check before me and I'll check after you and we'll talk about it. Um, but yeah, I felt like for me though, I don't know if you had any sort of, I can't even imagine what your own pregnancies were like, knowing as much as you do. But for me, it
It's
was like,
mentally exhausting.
girl, I was checking my cervix. I was doing ultrasounds every night at the hospital. I was telling Colby, like, she's got a bunch of hair. And he's like, I don't even want to know how you know that. And then I'd go in and they'd strip my membranes. And a couple of days later, I'm like, I'm like a good 1.5. Like, this is going to go well.
Yeah.
And he's like, I don't even know what that means. And
I walked in when I was in labor and I was like, hey, I'm 480 minus one.
yeah.
Let's do it. Hey, I'll just
Go ahead
die.
and give
Just
me a
like,
room. I'm gonna go right there. I know
ready.
which room I want. Yeah. But I think it's a sweet little way to know your body so much more. But it is daunting in and of its own,
Mm-hmm.
self that you do know a lot. And I would say a lot, like labor and delivery specifically, for the most part, your patients aren't sick.
Right.
So, for the most part, you're coming in this beautiful moment of their lives that
Mm-hmm.
they're going to remember forever. And you get to be a part of this family,
Yeah,
moment.
you're a part of their best day. That's what, I
Yes.
always walk into delivery room thinking this day is going to change their life. This is
Hmm.
one of their favorite days that they will ever have.
Yeah.
And I get to be a part of it, which is really cool.
That was my favorite. And people ask me all the time if I miss working as a nurse. And I can honestly say, like, every single day I miss it.
Really?
I can't, make working at the bedside work for our family
Mm-hmm.
schedule and routine and all those
It's
things. It would
hard.
be really hard. And I would only want to do that. Like, I would not want to work in an office setting. I would want to be at the bedside,
Mm-hmm.
pushing, even charting every 5 minutes if they're on, all of that stuff I love
Mm-hmm.
because you're sitting with them. You've got maybe two patients. At least that was
Yeah.
the rule back then. And I loved it. I
Mm-hmm.
loved it. But there are really, really hard moments.
Oh, there
And
are for sure.
even harder when you're having your own experience to then have to go into some of these really heavy rooms or heavy cases, being pregnant yourself or people seeing that you're pregnant. It's a whole thing that I think people don't even realize.
It is. It's hard emotionally, being a female in OBGYN. When I
Mm-hmm.
went through my pregnancies, of course, you know too much. So
Yeah.
every day I was worried that, my water
Mm-hmm.
was going to break at work, or I was going to have a cord prolapse or an
Mm-hmm.
abruption. It's like all
Mm-hmm.
the, major issues were
Yeah.
always going through my head. And like I was talking about earlier with social media, you see all these people that for people that have a home birth and it goes exactly as planned,
Mm.
good for you. That is
Yeah.
awesome.
Yeah.
And I wish it happened that way for everyone.
Mm-hmm.
But when you know all of those things that can go wrong, it just makes you so nervous because of all the what ifs.
Yeah.
What if you have a shoulder dystocia in your living room?
Mm-hmm.
What if you have a cord prolapse and you can't get to the hospital fast enough? It's terrifying.
Yeah.
But I will say, having my own pregnancies and going through the labor and delivery process, I wouldn't say it changed how I practice, but it gave me different empathy.
Yeah. Different perspective,
Yeah,
I'm sure. Yeah.
yeah. So it's definitely changed kind of how I coach people to push, how
Mm-hmm.
I see people with visits, how I do exams, just postpartum kind of tips and tricks that I have now that I didn't have before.
Yeah.
So that's been fun to see how it changes as I go through different phases of life with my patients too.
I'm sure. Well, and it will continue to,
Oh yeah.
right? Yeah.
Mhm.
Well, and I think too, a lot of people, I hear this from the the clinician's perspective, but also the patient's perspective of seeing someone that looks young and then automatically assuming they don't know what they're doing. I feel like that's a more older generation thing, but it still happens a
Oh yeah.
lot
Hmm.
of and I'm surprised it didn't come up more when I was nursing of like, have you had your own kids? No, I'm not going to listen to you. Like, no one ever did that.
I get asked that all the time.
I'm sure you
Yes.
do, right? Of like, well, then you don't know what it's like.
Yeah.
Well, yeah, I may not have felt it myself. And I will even say, I only have one child, and my one experience of birth does not come anywhere near all of the experience of just adjacent to birth, right?
Hmm.
Watching other people. I did not feel it. And to be perfectly honest with you, I had an epidural. I still didn't really feel it,
Hmm.
right? So it was
Hmm.
like
Yeah.
I had perspective, but I already kind of had that,
Hmm.
right? I didn't really need to have a baby to
To
see
know
the
that.
things that I
Yeah.
saw. Um, but yeah, oh my gosh, I feel like I could just talk and talk and talk and talk. And maybe some of this was like heavy medical stuff, but I just feel like that's where I naturally go. So if that
No.
was overwhelming, sorry,
I
ladies.
love talking about it.
But
Yeah.
there's so much I want to talk. Maybe you'll come back and we can do this on a different note because
Absolutely.
I think that the tides are changing. We were talking about pelvic floor physical therapy before we
Yes.
started. And I love that people are talking about that stuff more than they ever have before because
Hmm.
I think they're really late to the game, so to
Mm-hmm.
speak. Like there should have always been that, but that's just the nature of the world.
Mm-hmm.
But I
Well,
love.
mom and grandmother's generations always just were like, "Oh, get over it. That's what women deal
Mm-hmm.
with."
Mm-hmm.
And that's not how it has to be. And I
Mm-mm.
think now we're starting to see that women are fighting for, being advocates for their own health and for sexual health. And those are things that you didn't talk about before. So as our generation is becoming more educated in all of these topics, I really think it's helping.
I think that the narrative that I always kind of grew up believing as like a very young person, right, was when you have a baby, everything's kind of over for you after that. Like you're going to gain a bunch of weight. You're
Mm-hmm.
not going to be seen as a sexual person in any capacity. You're a mom. You're going to look a certain way, all that stuff. And then I think a lot of people probably just kind of accepted that in
They
so many
absolutely do.
ways.
Yeah.
And now it's like I don't want everything to be over after I have a baby. Like I still want to be sexual and have intimacy, but also I don't want to pee every time I sneeze and I
Right.
want to jump on a trampoline without a pad on
Yeah.
and stuff
You
like
don't have
that.
to live with those things.
That's right. Like it
Mm-hmm.
doesn't, we don't have to accept it
No.
anymore, but it does take like proactively advocating for yourself,
Mm-hmm.
asking questions, digging in. Like don't just peeing in your pants is common, not normal. You should not. You shouldn't, right? And
Yeah.
like just people telling you on the internet to do Kegels isn't enough for
No,
most
it's not enough.
people.
And I have women all the time that they'll just be there for their annual. And I
Hmm.
notice on exam, I'm like, hey, there's a lot of pressure down here. Do you leak when you urinate or when you cough, sneeze, laugh? And they're like, oh yeah, but that's just how it
Yeah,
is.
just normal.
It's like, what? That doesn't have to be
Yeah.
normal. Do you want to talk about it? And most of the time, that'll start a conversation. It's like, oh, well, I didn't realize that this was abnormal.
I love that
So,
you do that,
thank
notice
you.
that, and bring it up. I think that's so important. But yeah, I mean, any sort of education that you can give yourself, right, for anyone listening, but
Hmm.
don't be afraid to ask questions. I see that a lot with young girls that I work with. Most of them have IUDs, which that's a whole nother thing I could get on, of these like non birth, like they've not had children. um, but anyway, the STD prevention, things of that nature, but
Hmm.
also like not feeling comfortable asking or what to ask. They're embarrassed. A couple of at this point, it's been like 2 years ago. We made like this script for calling local health departments and
Hmm.
what to ask for and how to ask because a lot of people aren't comfortable talking on
Yeah.
the phone.
Yeah.
And some of these things you need to ask before you make an appointment to go in. At home STI kits that they can do, things of that nature, just to make it to where they're not like in their own mental prison of not wanting to
Right.
talk about it or tell anyone. And then another thing I've gotten a lot, which is like the antibiotics, and you can't drink on the antibiotics. And a lot of my college girls are like, I want to go out
Yeah.
and I'm
So I
not, and
just
I'm
wanted to
like,
go in and talk to you.
hold on a second, you know? So I think the more we talk about it, the better off we will be, not being ashamed to really trust your physician.
Hmm.
I've always been on the bandwagon of female OBGYNs my
Hmm.
whole life. And some people have, different views, and that's great. But just somebody you
Hmm.
trust,
Yeah.
somebody you can talk to, and you can ask these questions. It's so important.
Yeah. And regardless of, male, female, or young, old, I think having somebody that you trust and can
Hmm.
develop that relationship with is the most important thing.
Yeah,
Because I absolutely love my patients that, stick with me from the beginning and we just, ride through life together.
I love it.
And it's so much fun.
Yeah.
And the fact that, I'm honored that they trust me with such an important part of their life.
Hmm.
So the relationships are really fun. I love it.
It's really special to be like, I always say that from the coaching perspective, but it was very much the same as a nurse is like, I get to witness a
Hmm.
huge moment in their timeline. And that is such an honor.
Yep,
So
it is.
I love it. Emily, I loved this. I want to ask you one question before we finish up. So I named this podcast the Hype Squad podcast because the whole premise behind it was I want you to come on and I want you to teach me and be full of yourself and kind of brag about what you're good at because those
Hmm.
are like cringy
Hmm.
terminology. But I want you to share something that you want to be full of yourself about or brag about that you're really proud of achieving or accomplishing. Just
Hmm.
at least one thing
Hmm.
that you can brag about.
If I had to brag about something, I think it would be the way that I have been able to practice my time management with my
Mm,
boys. because I'm not going to lie, in med school, part of the reason that I was turned off from OBGYN was the schedule, right?
Mm-hmm.
Pagers don't care if it's your child's birthday party or your
Yeah.
anniversary dinner or some big family event because
Mm-hmm.
babies come when babies want to come.
Mm-hmm.
So part of me was very scared to get into this field, but I feel like I have, and still working on it. I wouldn't say quite mastered, but I have done well with, having two children. I have a great relationship with my husband and being able to balance mom, wife, physician, and be present for all of those roles at different times.
Mm-hmm.
And that can be really hard. So
Yeah.
I'm proud that I've
And
done
ever
that.
evolving, I'm sure.
Yeah.
Yeah. Yeah, for me, just balancing in general comes down to like grace. Like give myself
Mm-hmm.
grace. I'm not always going to be able to do everything. You only have 100% to give.
Yep.
Like so if you're on a call, 80% of your energy is going to go to that. So
Mm-hmm.
it's like being really realistic of how much you can
Right.
give, but also
Yeah.
having a supportive partner. You have two young boys, which is
Yes.
hard regardless of what you
So
do.
hard. And if I did not have, Ryan and his flexibility and ability to,
Yeah.
I mean, he's a better parent to the boys sometimes than I am because he can just handle bath and bedtime
You
like
tackle
it's
different
nothing.
things,
He
right?
he
You have
does
your
it.
own strengths for
Yes,
sure.
but his support means a lot, and I'm very grateful that I have that because I could not do what I do without him.
I love that you say that. That came up for me last week. I was bragging about Colby, my husband, on Instagram because I was like, somebody asked me and I never talk about him. And I just want to brag about him for a second.
Yep.
Like, I'm so proud of him. And one of the things I said, like getting on a soapbox, was nobody gets to where they are alone, especially if they have a family and
Oh
children.
yeah.
Like, you get there, it's like shared success
Mm-hmm.
ultimately. Like if for me it was like sometimes I would compare my success to his success and they're not
They're not competing.
comparable,
You're a
right?
team.
They're not competing,
Yes.
but they're also not comparable because we don't have the same 24 hours,
Mm-hmm.
right? And that's true for any family. It's balance,
Mm-hmm.
but it is a team effort and it
Very
is
much so.
shared success. So I love that.
Yep.
I love that. I'm
Yeah,
so
it's
glad you came to
much
do
fun.
this. Emily, thank you for your time
Yes.
and I
Thank
hope
you
you
for
come
having
back.
me.
Thanks for listening. Be kind to yourselves. We'll see you next time. Bye bye.